The last speaker is Dr. Lauri, who is going to talk about a very familiar issue, which is the new trends in the treatment of distal radius fractures. Is Dr. Lauri online?
Yes, I am.
Yes. Would you like to open your camera and your...
Sorry. I share. Do you see my presentation?
Yes. Would you try to open your talk? I mean, in the presentation form? Yes, great.
Yes, okay. It's a pleasure for me to present this talk. The new trends and treatment of distal radius fracture. I focus my presentation in treatment of a small volar periarticular key fragment. These fragments usually are fragmented behind the watershed line, fractured by traction on the capsular and the ligament insertion. Are consequence of volar displaced fracture, dorsal displaced fracture, or comminuted articular fracture. Are involved by traction of a volar extrinsic ligament or dorsal extrinsic ligament. The challenge is because the fragments are behind the watershed line. This is preliminary consideration. This fracture then can be treated by traditional plate. And if this fragment is not identified, there are a secondary dislocation of the carpus or volar or dorsal. It makes sense to use a marginal plate for this type of fracture. The fragments are very, very close to the joint. They are a long plate. This plate was a special plate. I use this is on the watershed line, and it's necessary to remove this plate usually because they are conflict with the tendons, and their long plate is not necessary. Why to use long plates when the fragments are marginal behind the watershed? In marginal fracture involving capsular ligament insertion, the best solution, in my opinion, is a fragment-specific fixation using headless screw, hook, small plate fragment-specific, or combination of this device. This is one of the first cases I treated. It's a very complex fracture, and I try to treat only using the screw. 2 lag screw, 1 headless screw, and 1 headless screw for most fragment, and 1 Kirchhoff wire. This is a fragment specific. This is a follow-up at 2 months, but it's interesting to see what happened after 4 years. There are no tricks. You see this is the pre-op. This is the CT scan after 4 years. In the left, the pre-op, in the right, 4 years. All this screw and Kirchhoff wire are inside, remain in the place. They have a good reconstruction of the joint surface. This is another example, the possibility to treat the dorsal small fragment. You see the fragmentation is possible to fix using only the headless screw. This is the hand. This is a 1 month. This is the CT scan after 10 months. You see the pre-op and the CT scan after 10 months. And this is the follow-up after 10 months. Another example, very marginal close fracture. You see the fragmentation at the CT scan. Only in this case, I use only 3 headless screw. I cross the screw for the joint surface, under the joint surface. Also in this case, I perform a CT scan to check the results. This is the pre-op at the 1 year. You see also in these cases, the screw are inside and the joint surface have a good reconstruction. This is a follow-up at 1 year. Now there are available other specific implant to fix this small fragment. Are the hook with one row of proximal screw, or other hook with 2 rows for the proximal screw, or other specific plate like you see in the both with 2 holes to put a small screw, or with 2 hooks. It's possible to use this hook alone or with screw. This is an example of marginal fracture with the SL ligament lesion associated. I use the hook to fix the small fragment under the scaphoid, an headless screw in the styloid, the reconstruction of SL ligament, and another small screw in dorsal aspect. These are the hand, the reconstruction. They are only screw and hook. And these are the CT scan after 1 year, the pre-op and the post-op. At 2 months, the follow-up. Is another example of a small fragment that you see here. Is very, very close to the joint. This fragment is very important to fix. You see is rotated. It stabilizes the carpus. I use in this case a hook, a double hook, and only one headless screw in the styloid. This is a 1 month follow-up. This is a more complex fracture, bilateral fracture. You see the dislocation of the carpus, dorsal-radial dislocation. I use also in this case is one hook, one micro anchor to fix the dorsal capsule, one screw in the styloid, the ulnar styloid, and one other headless screw in the radial styloid. I fix in this case temporarily the carpus with a Kircher wire for 2 weeks. The CT scan with the follow-up. Also in these cases, it's interesting to see the CT scan after 6 months. Another example, very comminuted close to the joint fracture. In this case, it's a little bit complex reconstruction. I use this new hook with 2 rows in the proximal part. I use a 2 headless screw in the styloid and 1 headless screw to fix the sigmoid notch, and 1 other headless screw in the dorsal aspect to fix the dorsal fragment. This is the follow-up at 2 months. You see all the implants are inside. These are recent cases. I haven't the CT scan to check what happened at the hand. If you are not sure the stability of the hook, it's better to cover the hook with another plate, one small plate, or it's possible to use this new plate with a hook. This is an example. The fragment is not very small. I use the hook and I cover the hook with a small plate. This is a 1 month follow-up. With I fix this, in this case, the styloid with the screw from the plate. Also in this case, I have the CT scan after 6 months. All the devices are in the right place. Another example. In these cases, I used this new small plate with a hook. It's better for not combine hook and plate. It's an alternative. Also in this case, I use a headless screw for the styloid. This is a 1 month follow-up. Other example, they have also a combination for scaphoid fracture. And this is 2 months follow-up. In other cases, all these fractures are a combination of fragmentation close to the joint. I use the hook and the 2 head screw to fix the styloid. This is at the end, the follow-up, the clinical follow-up. If you have a dorsal fragmentation, it's possible to combine double approach with the hook in the volar side and the plate in the dorsal. This is a complex fracture, very close to the joint, with the involvement of fragmentation volar side and the dorsal. I use it in double approach. I fix the volar fragment with a double hook, and I use a plate just to buttress the fragment in the dorsal aspect. And there are also 2 anchors to fix the capsular and the dorsal ligaments. This follow-up at 1 month and 2 months. Also in this case, I have the CT scan as a pre-op and 1 year. You have, I think there's a good reconstruction for this kind of fracture. If there are big combination of volar and dorsal fragment, it's possible to combine hook with dorsal plate and volar plates. Only in the selected case in young patients, this is a terrible fracture, very close to the joint, completely fragmented and completely rotated. I use a PL plate with hook to the volar side and 2 small dorsal plates. This at the hand. You see there a fragment here is not well fixed. This is the range of movement when I decide to remove the dorsal plate. You see this is the fragment. I remove this fragment. And this is the follow-up after dorsal plate and dorsal fragment removal. If you have a combination of volar fragment, it's possible to combine the hook with the traditional plate, or in selected cases to use this new special plate with the 2 holes to fix the anchor. This fracture, you see ever a small fragment to the joint. This special plate. Is the reduction is important and accurate reduction. The fragment, the position, to check the position of the plate. And you see there are 2 small screws to fix the volar rim. This is a 1 month follow-up. At the end, I think that the recommendation is do not underestimate this lesion. It's very important to see the first X-ray, because after reduction, the fracture appears in right position. But you perform a CT scan, you see there this fragment is extremely important for the stability for the carpus. In this kind of fracture, is ever necessary to do a surgery. Another recommendation, accurate surgical exposure. It's important to open the palmar sheet of flexor carporadialis to see very well the watershed line and the part of the radius behind the watershed line. Is to push the hook against the volar rim. And another recommendation, make attention to the orientation of the screw, because they are very close to the joint. Is the high risk to put the screw inside the joint. It's better not fix the screw at 90 degrees, but to to push the screw from distal to proximal. If you are not sure of the fixation with the hook, or you use a double hook with a 2 row, or it's better preferable to cover the hook with a plate. The PL plate is perfect because go very, very close to the watershed line. This is my series from 2 years. In 2 years, I publish the preliminary results in the journal Wrist Surgery. In small periarticular fragment, addle screw, hook, small plate. What else? Arthroscopy. I think arthroscopy is not very helpful in this kind of fracture because there are involvement of extrinsic ligaments. Thank you very much for your attention.
Mr. Corbillas, we can hear you.
Thank you very much, Dr. Lauri, for this talk.